Ladies and gentlemen, my name is Stephen Cross. I'm a PG Rob 1 pharmacy resident at Erlanger Health System in Chattanooga, Tennessee, and today I'm here to present my research, which is an evaluation of a pharmacist-driven, methicillin-resistant Staphylococcus aureus polymerase chain reaction screening protocol for pneumonia. Neither myself nor my preceptors have anything to disclose at this time. For some background, methicillin-resistant Staphylococcus aureus is a common empiric target in patients presenting with pneumonia, and more often than not, vancomycin is the drug of choice for these patients. Vancomycin in and of itself does have its own issues, which can include an increased risk of nephrotoxicity, which can prolong hospital length of stay, as well as increase overall hospital cost. Limited de-escalation tools exist for patients with pneumonia until recently. More often than not, this was guided by sputum cultures, which may or may not give good data for de-escalating antibiotics in patients with pneumonia. The MRSA polymerase chain reaction, or PCR assay, is a tool that has emerged recently due to its high negative predictive value for patients with pneumonia. Data showing the strength of the MRSA PCR led our institution in June of 2018 to develop a new protocol that would allow a pharmacist to automatically order an MRSA PCR, follow the results, and with a negative result, automatically stop vancomycin therapy. A little more about our institution. We are a tertiary care as well as a level 1 trauma center with 838 total beds located in Chattanooga, Tennessee. The purpose of our study was to evaluate pharmacist impact on vancomycin days of therapy after implementation of a pharmacy auto-stop policy based on MRSA PCR results. Our primary objective was duration of vancomycin therapy in days, with our secondary objectives of 30-day readmission, hospital mortality, hospital length of stay in days, incidence of acute kidney injury, or AKI, number of vancomycin levels drawn, and incidence of antibiotic re-escalation in our post-protocol group. This was an IRB-approved, single-center cohort study. Our patients were selected by admission date via electronic medical record report with our pre- and post-protocol dates listed below, and all data was collected via chart review. Our major inclusion criteria: all of our patients needed to be 18 years of age or older with a suspected pneumonia diagnosis in chart. We excluded patients who were admitted to an intensive care unit while on vancomycin. These patients are normally higher acuity, therefore we did not want to automatically de-escalate vancomycin in these patients without first speaking with a provider. As well, any patient that had a concurrent infection requiring vancomycin was also excluded. Our patient selection broke down as such. We screened 561 total patients with pneumonia who received vancomycin. This broke down into 129 in our pre-MRSA PCR protocol group and 139 in our post-MRSA PCR protocol group. It's important to note that we excluded a large number of patients due to an intensive care unit admission during their stay. Our demographics are as such. While mostly similar, it is important to note that our community-acquired and aspiration pneumonia affected more patients in our post-protocol group in comparison to hospital-acquired pneumonia, which affected more patients in our pre-protocol group. Which leads us to our primary outcome: duration of vancomycin therapy in days. Our pre-protocol to post-protocol group saw a clinically and statistically significant reduction of 1 day, which helps to show the impact that a pharmacist can have on reducing days of vancomycin therapy for patients with pneumonia. As well, for secondary outcomes, 30-day readmission, we did have more patients in the post-protocol group, though this was 30-day admission for any reason and may or may not have been related to an infection. Hospital mortality and length of stay in days were similar between both groups. While not statistically significant, we did have a clinically significant reduction in incidence of AKI, as well as median number of vancomycin levels drawn was both lower in the post-protocol group. We did have one incidence of antibiotic re-escalation in our post-protocol group. This was a methicillin-sensitive Staph aureus that was from a sputum culture, so before it speciated as methicillin-sensitive, the provider did not feel comfortable, therefore we re-escalated. But to have one incidence of antibiotic re-escalation in 139 patients goes to show that our providers were on board with this new protocol. Our major limitations, this was a retrospective chart review, meaning that we were only able to go off of the information that was presented. As well, we had issues with protocol compliance, which led to potentially longer durations of therapy in the post-protocol group. Protocol noncompliance was defined as a patient who had an MRSA PCR ordered but not collected within the first 24 hours of therapy, which led to at least a 1-day increase in vancomycin therapy. As well, as mentioned earlier, we did exclude a large number of intensive care unit patients. For our conclusions, we did note that a pharmacist-driven MRSA PCR screening protocol significantly reduced days on vancomycin therapy. As well, we had reduced incidence of acute kidney injury, and we drew fewer overall vancomycin levels, which led to decreased need for pharmacist monitoring, as well as nursing workload. We did also see non-significant changes in hospital length of stay, in-hospital mortality, and 30-day readmission. For our self-assessment question, did a pharmacist-driven MRSA PCR screening protocol reduce days of vancomycin therapy for non-intensive care unit patients with pneumonia? Our answer is yes. These are my acknowledgments. My email address is stephen.cross@erlanger.org. I'll be happy to take any questions there, and I thank you for your time.